No, I'm just very happy to be here. And thank you so much, Mike and the Databricks team, for organizing this. And to all of you, thank you so much for taking time of your day to come to listen to us. Each and every one of us, I can speak from different perspectives about what I'm going to talk about and what we are doing at Tufts Medicine with data and analytics. But to sort of set the stage, I just wanted to let everybody know that this is directly affecting everybody. I'm speaking not as a data officer for a few minutes, but as a patient. Everybody in the room is a patient at some point in their lives. Everybody, there is no exception, regardless of your demographic and your background, it doesn't matter. You all are patients, I'm a patient. So I would like to, when I speak, when I do talks, I'd like to talk from a patient perspective first to sort of internalize what is it that we are really talking about and what is it that we're trying to solve. It's very, very important. The second is, I just wanted to ask the audience, is anybody in the audience a provider, or an MD, a clinician, or a nurse? Anybody in the audience today? No clinicians. So the second perspective is also to understand that our clinicians do amazing work. They are our heroes, so they all deserve a round of applause, believe it or not. They're not here, but they deserve a round of applause because they do provide relentless care. And to give the context to what that means, there are 5 core measures that Common Good Fund, there's an organization that actually measures quality of healthcare for countries globally. And they selected 11 countries and they sort of did surveys using WHO data and some other data sets to rank 11 countries. These are all Western first world countries, modern countries, if you may. I'm from third world country, so I don't even get into that bucket. But that's a different story altogether. And unfortunately, again, I'm speaking as a patient, unfortunately, United States of America, our great country, is last in that group of 11 countries. And the 5 core measures that this fund collects the data for is patient access, care process, administrative efficiency, equity, and lastly, outcomes, clinical outcomes. And out of these 5 measures, United States of America is last in 4 of them. I say last, at the bottom of the chart. There is only one measure that we are second to Netherlands, and that is in care process. So what that tells you is that our providers are doing a darn good job because the care process is pretty equitable compared to our peers, the 11 countries that we get measured against. And the other measures, we are in the bottom of the rank because not everything is in a provider's control, or not everything is even in a provider organization control. There is policy, there is health equity, there is income gap, there is insurance, there is payers, there is pharmacy. The gentleman this morning talking about pharmacy management. All these players have muddied the water so much that United States of America is last in terms of how we measure to other countries. That is my patient perspective. And everything aside, we are trying to solve that problem. We are trying to solve the problem. So as an organization, we are not too big. We are not the biggest organization out there in terms of healthcare, and we are not small either. How do I go to the next slide so that I can talk about Tufts? I don't have a clicker. Oh, clicker is right here. Thank you. Agenda, I'll get to the agenda. It doesn't matter. I'm going to go off script a little bit, but not important. Me, like I said, I'm a patient. I'm also Jawad Ali Khan, like Mike said, Chief Data Officer. Our organization is an integrated health system. We have almost 1,100 plus beds we manage. We manage close to 500,000 lives in managed care. We have touched at some point in our existence as a health system over 3 million lives. So we are not too big, we are not too small, we are right size. We are just about the size of organization that I think we can be a change agent in the story that I painted, because we can manage the care in a way that maybe it's difficult for a large organization, and we can manage care in a way that it might not be possible for a very small organization. So I believe that we are right sized, and that's why we believe that we can make a difference. With me also is Siv. Siv, go ahead and give your introduction.
Hi, I'm Dr. Shiv Raman. I'm one of those providers that Jawad was talking about, except I moved to the IT side, and so I'm trying to help providers with these health information technology and data processes that we are so much into.
Thank you, Siv. I basically talked a little bit about Tufts. We are Tufts Medical Center, we have Melrose Wakefield, we are Lowell General, and we have Lawrence Memorial Hospital as part of our network, and we are an integrated network where we are managing lives, like I said. And we have a very large home healthcare foundation. We do provide, we have home healthcare agencies spread across Massachusetts, so that's also unique, and it actually adds to what I'm going to say as part of the journey for us. In order to solve the problem that I talked about as an introduction to my discussion today, it was important for us, obviously, to align the data analytics strategy to the mission of the organization itself. That is very, very important. Mission alignment, IT business, analytics business, data business is key. Because the mission of the organization is to provide frictionless care. Remember the access issue, we are last in the world in terms of how we have provide access to the patients. We wanted to solve the problem and see if we can do frictionless care. What does that mean? What that means is, today, how many of you have to call a friend to see if you can get an appointment ahead of the list at a clinic? Right? It's a common problem. I get many times calls from friends and relatives to say, can you give me an appointment with so-and-so doc? I call the office, he's not available for 6 months, 4 months. We go through all of that, and I think that should not be the case. I should not be using preferential, to my connections to bring people up the queue. That is not the right thing to do. The case access should be available. So when we say frictionless care, we're talking about open scheduling, understanding transparency in terms of prices, understanding who you are seeing and what the chances are for a good clinical outcome for the disease that you're dealing with. Right? We are trying to solve the problem of making sure that there is equity in care regardless of where and how you come from. That is what frictionless care means. And that doesn't necessarily come from looking at just the process or looking at just IT. It comes from tackling this problem as an organization whole, right, together. And we wanted to do that by really putting a data and analytics strategy together. It was one of the key elements to make sure we are successful in providing frictionless care. So the strategy was really to then understand what is in need today for operational data, what is in need today for doing advanced analytics to make sure that we can bring research and operational clinicians together, and what is it again to understand how we can provide better and enrich data to our medical research community. That strategy had to cover all those three different foundations, all three legs of the foundation. And our challenges were massive. Not just that we are trying to understand and place ourselves in a place where we can be a change agent for the healthcare itself, but also sort of understand what are the deficiencies within our four walls. How are we dealing with our data sets, our data assets today? How are we converting the data to really have a value? To speak to data, data is gold, the adage. It is not gold until you turn data into information, until you turn data into intelligence. So we wanted to see how internally we are structured, what data is available to us and what is not available, and we had some problems. The problems in the sense, we were Tufts Medicine system, but our hospital systems were loosely connected. Everybody were doing their own analytics. There was no enterprise analytics in place. people couldn't get a system view of what was happening. As a patient, when I'm calling into my medical center, I am not able to see what's happening at Lowell General as opposed to what's happening at Tufts Medical Center, because there was no systemness to any of that. So we really wanted to tackle this problem from a system perspective, and then bring the data and information together so that we can actually make decisions at a system level. So we had massive data volumes, siloed systems, fragmented processes, and again, lack of unified analysis, as the story goes. So we then started to unify this data and data sources. One of the key challenges in unifying healthcare data is to sort of normalize the data in a way that it is a true common data element. There is so much variability of care that each system that an institution employs for care has a different data model, have a different shade of data, have different data qualities, have different data processes, and it's very, very difficult to sort of normalize that. And we thought through that problem, understood, or we tried to understand what the industry is doing in terms of organizing the data in a way that it makes sense and can sort of come together on a common synthesized data layer. And we chose, believe it or not, there are not many people who are doing this, but we chose FHIR, which is a fast healthcare interoperability resource, as a protocol to even organize our data. So we converted data from all of our legacy systems into a FHIR data model. That way it is unified and it is inherently ready to be interoperable. It is not sufficient. If I'm going too much technical, stop me, and I'll sort of try to make it sound more business. The idea, again, is to synthesize and normalize the data to a common data model. In healthcare, systems understand one or two formats to exchange data. From very early on, data used to be exchanged using a format called HL7. Now HL7 has sort of matured towards a FHIR data model. FHIR data model is a little bit more, how should I say, a little bit more flexible in what data you can put in it, because it is semi-structured. It is technically a JSON file, if you think of it that way. It's semi-structured data. So what we did was we used all of our siloed systems within our organizations. And I'll tell you why Databricks played a key role in their process in a minute. But we looked all of the legacy systems. All of these legacy systems have their own proprietary data models that does not conform to any common data model standards. And we actually took all of them and normalized the data to the FHIR schema, to the FHIR standard, in order for us to be able to create a unified data platform. So that this platform is inherently interoperability ready. Because at the end of the day, from a patient's point of view again, if I want my care to be holistic, regardless of where I live in Chicago. Today's world is such that I live in Chicago, but I work in Boston. Nobody knows if I can get sick in Chicago or in Boston at any given time. Why should my data not be able to interop between where I live and where I work? I want to be able to go to a clinic just around the corner and have them see my data that was seen by a provider in Chicago. Why is that hard? My bank can do that. I can walk into Chase in Chicago and Chase in Boston. They will have the exact same record. We have not solved the problem in healthcare. We are getting there. The EHRs of today's age are solving the problem to a great extent by programs like Care Everywhere, where you can send, but you still have to be in a common platform. There's still boundaries, there is still friction. So we decided to sort of take away the friction. That's why frictionless care with frictionless data. We wanted to organize the data in a way that is inherently interoperable, so that a system in other country, in other state, wherever I may travel, is able to access and request my data, so that my data can move from point A to point B. That was one of our goals. Again, as a patient, we are trying to solve this problem as a patient first and then as a provider, right? So we organized the data using unified data platform. We normalized the data to FHIR. We made it inherently interoperable, and we provided this data as APIs for the applications to become very important. And why is that necessary? Why is data as API one of our key strategies? It's again because in healthcare, the transformations are happening at two levels. There are many levels, but I'm going to talk about the two high-level levels, right? A very high level. One is the transformations are happening because systems are coming together. The systems are becoming larger and larger. So you might have read many news items in previous months where systems are converging and becoming bigger. So the strategy in healthcare industry today is either you become big or you get sucked into a bigger health system. That's the only mode of survival. You got to get big or you got to get sucked in. Institutions like us, who are not big enough, who are not smart enough, at the risk of that, we are on the fence. We can get acquired or we have to get bigger. So the only mode of survival for us is to figure out other modalities of the data. How can we provide care outside of the four boundaries of the hospital system? Because believe it or not, the data informs us that building another hospital system with 500 beds is not profitable. We are not going to make money. And as a patient, I am not getting in any better, providing better care for my patients. So that strategy is not going to work. So the data and the modality of the healthcare is shifting from patient being within the hospitals to being a consumer. When patients become consumers, they want to consume health services just like they're consuming any other service, and that's when data as API becomes necessary. So what we have set up as a foundation is only table stakes. As the institution is going to now take next steps, next journey towards understanding how they're going to expand and go towards this journey of being from patient to a consumer, we should be ready to provide the data so that it becomes accessible. That's why it was so important for us to think about not just having a unified data warehouse, but also have the data in a way that it is interoperable and it is available as APIs. Right? So this is why we thought through, we were deliberate in our approach, and I believe the story of Databricks, I'm not a sales guy, but I'm just going to tell you the story of Databricks. Fundamentally, the concept is you need to separate compute from data. We were stuck at one point in our lives by managing compute and data all together in a single box. And that limited what we could do with the data. That limited what we could do with our analytics. That limited what we could do with data as data being API and supporting multiple modalities of the data forms, different data forms. Data will morph easily if it's together with the compute. So the Databricks platform essentially provides that flexibility where you're not thinking about the compute, you're focusing on data, and compute can be run separately. So that's the beautiful, it's the decoupling of data and the compute that brought us to this journey of how we use the data platform today. 12 minutes. Okay, so next slide. This is the WISE platform. As if we did not have enough acronyms, we carved a name for the platform that we built, and it's called WISE. It's called WISE because it stands for Wellness, Intelligence, and Information Sharing Enablement. So think about everything that I talked about as a patient, what we were trying to do to shift the needle to provide better care, faster care, easier care, easy access. And the reason was wellness. We all do sick care management, we don't do wellness management, and we thought we're going to build a platform so that it supports both hospital systems, outside hospital systems, data interoperability, and all that I just talked about. So WISE is, like I said, it's a FHIR-based lakehouse that we've built and deployed at Tufts Medicine. It is live today. It is serving I have my teammate Chris Giancola, hands off to him. He's managing the product and the team, and it's, I believe, going well so far. We can leave this for question and answer. I can definitely talk more about what the platform is and how it runs today in Azure Databricks as part of question and answer, so that I can just quickly finish the slide deck that they took so much time to prepare for me. Next slide. What is next slide? Oh, it's not moving. Okay, next slide. back to Siv. Siv, you want to talk about the architecture and the
Sure.
implementation process a little bit, then you can.
Yeah, so 314E, we are a health IT services and product firm. We are Databricks implementation partners for healthcare organizations. And so we were brought in by Tufts Medicine in order to work with their resources to build out this Databricks healthcare lakehouse, WISE. Now, this is our implementation plan, but as famous data engineer and boxer Mike Tyson once said, everybody's got a plan till they get punched in the mouth. So, we had this implementation plan, but it was a work in progress because we were running into some challenges. There were data challenges, process challenges. We're still working through some of them. But overall, what we did was, as Jawad said, his and the organization's vision to map everything to the FHIR resource. So multiple EMR systems, each of them have their own schema, way of representing data. We mapped all of that to FHIR. And so the Databricks WISE Lakehouse is basically bringing in data from all of these sources and persisting it in a FHIR schema. So what that means is, no matter where this data comes from, as long as it's clinical data about patients, you can use it for analytics, for reporting, for AI and ML and whatever else. And we use standard pipelines. We used a lot of heavy lifting PySpark jobs written in Python to bring that data in. We also used some cloud-based tools like Azure Data Factory, which is similar to the old school Informatica, but running on the cloud. We transformed all of this data to FHIR. We persisted it, and then we built some APIs, because we also had an archive job to do, because a lot of the legacy systems, we were archiving those the data from those systems. And so we use the open source part of Delta Lake to build the archive, but the data warehouse is built on a Databricks, Azure Databricks Lakehouse, implemented as on the cloud. And then all of these use cases that you're seeing, I think that one of the first presentations talked about whether you're using Power BI or Python or R or APIs that you're delivering the data out with. All of those are exquisitely supported by this WISE Databricks Lakehouse.
Thank you, Siv. Well said. So, yeah, some of the challenges that Siv talked about, literally laborious work to hand map every source system to a FHIR element to make sure that it is complete. Sometimes where FHIR resources are not sufficient to cover all of the data, you have to extend those FHIR resources so it's a little bit extendable. That's why we chose FHIR. That was hard work, and our developers worked really, really hard. So hands off to 314E for helping us through that mapping process and making sure we have all the source systems mapped to FHIR. And the clustering, the transformation layer, we were at one time, as we were starting this journey, we were transforming a lot of data. 3 million patients in our health system, so it required quite a bit of compute. So we would spike up the nodes, and that's the beauty. Like I said, don't think about data and infrastructure together anymore. They're too separable. You can put as much data as you want, and the compute just expands, right? Obviously, previously they talked about how to make sure you have policies in place so that you're not overspending, but sky's the limit. Databricks can really scale. You can put as much data as you want to the platform, and the platform will be able to crunch it. It's really up to you how much policies you want to set to crunch it in a set of time or a longer period of time, but nonetheless, the process works very, very smoothly. So this, Siv talked about the implementation work. I'm going to quickly go in because we have just 6 more minutes left. Frictionless data, I talked about this quite a bit. Agility, data democratization, unified approach, data first. Not much to add here. Transformative use cases. Yeah, so we use the same platform for multiple solutions, multiple use cases. Data conversions, data archiving, everyday analytics. Like today, if you walk into any health system, either they are dealing with the legacy data from their past transformation to a new EHR, or they are actively doing a transformation to a new HR. That's the only two phases. So health systems have legacy data, and the legacy data is actually patient charts. You won't be able to have a longitudinal history of a patient unless you take that data from the legacy system and transform it into a lakehouse. So it's very, very important. And many institutions, unfortunately, do not tackle that problem. They think of conversions, legacy data, and data analytics as three different solutions. It's not. It's a single solution, because the common denominator for all of those is data. You do really want all the patient's longitudinal history to be able to have a quality outcome and a quality clinical process. And that's why it's so important. So we use the same platform for all of that. One platform for archiving, one platform for conversions, active conversions. There are many, many systems that we are converted, and truth be told, there are many more systems that are yet to be converted. Average count of clinical systems in a hospital today, we think that it's only EHR. No, there are 50, 60 other ancillary systems that dermatology uses, that cardiology uses, that cancer people use. All systems and data cannot be siloed. So you got to start thinking about bringing the data together. That's why it's important. Conversions are always happening. We are always archiving, and we are currently serving all of the operation analytics using the same platform. So next time you guys get this vendors talking about, I'm going to archive your data, and another vendor coming and talking to you about how I'm going to convert your data from a system to a system B, and then a third vendor coming and talking to you about saying, I'm going to provide you an analytics platform, say no. You got to be able to solve the problem using a single system, because your data is the common denominator, and data is an asset. You really cannot improve and provide frictionless care unless you have frictionless access to all other data. That's my story, and I can end there. Do I have any more slides? Yeah, but challenges, solutions, business impact, I talked through all of that. We have 3 minutes, and I'd be happy to answer any questions. Thank you. Yes, sir.
Yeah, I'm kind of at the age where I do spend some time in the doctor's office.
Yeah. We all do, trust me.
Oh, yeah. My question, though, is this: when I come into the office, the nurse will fire up my record at Epic. I noticed on the architecture chart it says Epic Data Conversion. One of the questions here is, now you have a FHIR standard. Epic seems to be almost ubiquitous. Is there a standard Epic data conversion? And do you go in the opposite direction too? Can you talk about that?
Yeah, that's a great question. So somebody with insight into what's happening with conversions. Epic deals with data in a very different way. It's not common. So they almost define different data as data types. For example, they will say encounter is a data type. Patient record, EMPI, is a data type. Lab is a data type. Those are data types for them. And they have different formats for all of those data types to be ingested into Epic. For example, if you want EMPI, they will only take a CSV. The demographics organized as a CSV file, and they'll ingest that into the system for the EMPI process to be converted. For labs, they will take a HL7. For encounters, they will take HL7. For appointments, they won't take nothing. You need abstractors to be able to type that in. There is no automated programmatic way of converting appointments, future appointments, into Epic today if you're going live with Epic. So you have to really work with Epic to give them the data in the format that they want for each of those data types that are described. So what we did was, our platform today not just converts data from source systems to our FHIR-based schema, but it will also take the FHIR-based schema and do a reverse conversion to either HL7 or CCDAs or CSVs or whatnot. Because in Databricks today, again, that's the advantage, right? If you use the Lakehouse architecture, today my developer can come in and he can write SQL on top of the data. He can write Python on top of that data. He can access my Delta tables using APIs. So really, any format we will be able to convert from our WISE platform to a N format, whatever the format is, and coming from whatever format into FHIR is a process that we have already figured out. So you can go either way, but that's a very, very insightful question. Sounds like you have dealt with Epic implementations. Okay, very good then.
Just dealt with Epic and the doctors.
Beautiful. Any other questions? Yes, please.
I think we can take one more.
Hey, it was a great presentation. I work for MGB, Mass General Brigham, and we are going through the same journey now.
Beautiful.
We have 5 years, and you know MGB is a large organization. And I just wanted to ask one thing about, from a maturity perspective, right? And that's the biggest thing I feel. What was the maturity curve when you, I think this, is it still going on or is it all done?
Oh, we are in infancy. We are wearing diapers still. Yeah.
So yeah, that's the maturity curve. I wanted to know what is the maturity curve here.
Yeah, so we started on this journey, Chris, 2021? Yes. Early 2021. And in 2022, I'm very proud to say that, not without the help of the team and the guys here, we're very proud to say that the system is in production. It's running. We are running multiple use cases. We went live with Epic in April of 2022 from 24 different EMRs. We converted data into Epic using the same platform. So talk about sublimation, right? From solid to gas, no liquid stage in the middle. That's how fast we moved to get this Epic conversion completed and be live with Epic. Now, there are growing pains, to your point, about how this information becomes available to our researchers, how this information becomes available to our daily operational people. Analytics is, the guy before the talk said that it's not a silver lining, it's not a silver bullet. So yes, it takes time for people to come learn the tools and be able to access and learn the data. We are going through the journey. We are doing trainings every day. In fact, we had a training, Databricks-led training yesterday, literally, hearts of the press. People are still going through those labs. Thanks for the champions back there for helping us train our teams. So it's a process. We are 2 years, 1 year into production, and we have done use cases that were engineer-led, but we are really trying to push the system to the business, to the end users, and that's a journey. That's a maturity curve that I don't think maybe next year when we come and give a similar talk, we'll be able to share more stories about what that maturity is and what does it look like from the business perspective community. By the way, anecdotal information. I applied for Innovation of the Year for this product at the Databricks conference. I did not win. Sucks. I thought I thought it was the best damn thing in the world. I mean, I still believe it is. Who calls a baby bad ugly, right? It is. I mean, I honestly think that it's a repeatable process. It can be done at any institution, and it has inherent benefits. I'll apply again next year for the Innovation of the Hour product, and I'm damn going to win it. I know that.